Hey everyone, and welcome. If you're a pharmacist, you know this scene all too well. A new prescription for an ADHD medication lands on your counter, and right behind it is a patient or a parent full of questions. You're on the front lines, and they're looking to you for clear, practical advice. So that's what we're going to do in this explainer. Build a complete counseling toolkit so you can tackle those questions with total confidence. Let's jump right in.
First up, we'll do a quick refresher on ADHD itself, just to get our bearings. Then we'll dive straight into the first-line therapies, the stimulants. After that, we're going to spend a good amount of time on managing common side effects, because let's be honest, that's the heart of a great counseling session. We'll also look at what to do when stimulants aren't an option. And we'll wrap up by really zeroing in on the crucial role you play in all of this.
All right, Section 1. You know as well as I do that ADHD is one of the most common neuropsychiatric disorders out there. And that means you're the one fielding all those tough questions about symptoms, medications, and what patients should expect. Our goal here is to arm you with the clear, confident answers you need.
So just to make sure we're all starting from the same page, let's nail down the clinical definition. ADHD is really defined by this persistent pattern of inattention, hyperactivity, and impulsivity that's just, well, it's out of sync with the person's age and development. And it's not rare. We're talking about a condition that affects up to 12% of school-aged kids, and, as we now know, often continues right into adulthood.
Clinically, you can think of ADHD symptoms as falling into two main buckets. On one side, you have inattention, making careless mistakes, getting distracted easily, losing things. And on the other side, you've got hyperactivity impulsivity. This is the constant fidgeting, the feeling of being on the go or interrupting others. Now, a patient might lean more towards one type, but more often than not, it's a mix of both.
So, what do we do about these symptoms? Well, the primary tools in our toolkit are the stimulant medications, and the consensus from major guidelines, like those from the Canadian ADHD Resource Alliance, is that long-acting stimulants are absolutely the first line of defense.
And here's the reason why they're first line. A solid 70% of patients, and that's a conservative number, see a real, clinically significant improvement with stimulants. That is a huge success rate. It's also a powerful and really reassuring statistic you can share directly with patients and their families. It helps set expectations and builds their confidence in the treatment right from the start.
Now, it's not quite as simple as just stimulants. They fall into two main families. You've got your methylphenidate-based meds like Ritalin and Concerta, and your amphetamine-based ones like Adderall and Vyvanse. In terms of how well they work, they're pretty similar, but there is some, and I stress some, limited evidence that methylphenidate might be a better first try for kids and amphetamines for adults. Honestly, though, the choice almost always boils down to how an individual patient responds.
Okay, this is where you, the pharmacist, can be a total game changer, especially for kids or anyone who has trouble swallowing pills. You can tell them that capsules like Adderall XR, Bifenton, and Vyvanse can actually be opened up and sprinkled on something soft like applesauce or yogurt. Vyvanse is even more flexible, you can mix it with water. And here's a crucial tip for sleep. Make sure that last dose of immediate-release methylphenidate is taken before 4 p.m. to avoid insomnia.
All right, let's get into what is honestly probably the most critical part of your job when it comes to these meds. Proactively counseling on how to manage the common side effects is what makes the difference between a patient succeeding on a therapy versus them just giving up way too soon.
Appetite suppression. This is probably the #1 concern you're going to hear about. Your go-to piece of advice here is to take the medication with a meal or right after, never on an empty stomach. You should also encourage them to pack in nutrient-dense foods when their appetite comes back, which is usually in the evening. If that's still not enough, it might be worth talking to the doctor about a shorter-acting version to free up more appetite later in the day. Next on the list, cardiovascular effects. Now, serious issues are pretty rare, but monitoring is non-negotiable. We're talking about checking blood pressure and heart rate before they start, again in the first few weeks, and then about every 3 months after that. And you need to tell patients to report any sustained fast heartbeat or palpitations immediately. That's a red flag that means it's time to call the doctor.
Right up there with appetite is trouble sleeping. Your first line of attack here should always be counseling on good sleep hygiene. The basics, like cutting out screen time before bed. If that's not cutting it, there are a few other levers we can pull. Taking the dose earlier in the day is a simple fix, or it could be time to discuss a dose reduction, or maybe even switching to a shorter-acting formula so it wears off well before bedtime.
But what happens when a patient just can't tolerate the side effects of stimulants? Or what if they just don't get the response we're looking for?
That's when we have to look beyond our first-line toolkit and explore the other options we have. And this is a scenario you see all the time, right? Maybe the side effects are just too much, or the patient has a coexisting anxiety disorder that stimulants could make worse, or maybe there are concerns about the potential for substance abuse. In any of these cases, you need to be ready to talk about the second and third line agents. So the main non-stimulant player here is atomoxetine, which you probably know as Strattera. There are two huge counseling points you need to hit. First, you have to manage expectations. Unlike stimulants that work fast, atomoxetine can take a full 3 to 4 weeks to reach its full effect. Second, and this is a massive advantage for some patients, it is not a controlled substance and has no potential for abuse. That's a key differentiator.
Another class you need to know about are the alpha-2 agonists. Think guanfacine and clonidine. These are really good at targeting hyperactivity and impulsivity, though they don't do as much for inattention. You'll definitely want to counsel patients on sedation and maybe some low blood pressure. But listen, if you remember one thing from this section, make it this. These drugs absolutely must be tapered slowly when they are being stopped. Stopping them cold turkey can cause a dangerous rebound spike in blood pressure. That is a critical safety message.
So, as you can see, managing ADHD therapy is so much more than just putting pills in a bottle. Your expertise in counseling, in monitoring, and problem solving is absolutely central to making sure your patients get the best possible outcomes.
So let's boil this all down into a few key takeaways for your practice. 1. Long-acting stimulants work for about 70% of patients. 2. Proactive counseling on appetite, sleep, and heart effects is a must. 3. Use different formulations to get dosing flexibility. 4. Know your second-line options, especially atomoxetine's slow onset and lack of abuse potential. And 5, and I'll say it again, always counsel on tapering those alpha-2 agonists. Nailing these points will make a huge difference.
And I'll leave you with a final thought to chew on. Our whole understanding of ADHD is shifting. We now see it less as a childhood issue and more as a lifelong condition. So what does that mean for us? How is the pharmacist's role going to evolve to meet the needs of long-term therapy and patient safety? That's a big question, and it's something for all of us on the front lines to think about.